Okay. So actually today we will just try to understand a very important scenario which is asked frequently in almost every anesthesia exam, and it is related to hip surgery. Okay. So first of all, we will just see that if we have an old man with hip fracture, and now to fix it, if you can mute your mic, please. Okay, so they have to fix the fracture. So what are the consideration in this this patient? Because this may be elderly patient, so all the concerns related to elderly, altered pharmacological, physiological, and anatomical consideration. Okay, there is a long list of changes in the physiological system, pharmacological, pharmacokinetic differences, and then altered response to stress with reference to cardiovascular system, some mechanical changes in the lungs and the volumes and capacities, and all these things in detail. Okay, so this is one buzzword for elderly patient. Okay, then similarly there will be something related to hip fracture. So hip fracture, maybe you have to see whether the fracture result from fall due to some systemic problem. Okay, that maybe there may be any signs of any involvement of any CNS or CVS or respiratory system or endocrine system, okay, which lead to a fall. Okay, so this is also, you have to think about it. So this is one thing. And then other thing, that whenever there is fall, they may be one thing will be the fracture of hip, and the other, there may be associated injuries. Okay, so even if, for example, this is not a trauma, still there may be associated injuries. There may be, when that old man fall, that maybe he has some other injuries as well, in addition to whenever we are thinking about management of this patient, we have to be careful. We have to be aware of these things. So in addition to that, the patient will have pain. Okay, there will be, because it will be depending on the history, how long is the history, but there may be bedridden patient. Okay, so there will be more chances of DVT and pulmonary embolism. With long bone fracture, any long bone fracture, there will be chances of fat embolism. Okay, and then another thing is bleeding. One bleeding is during the surgery, and one bleeding is the when the fracture occurs, there will be bleeding inside the cavity. So we can expect 1 to 1.5 liter of blood loss. So patient may be anemic. So these are the things. Pain, not only the pain which is occurring at that time, any change in positioning will be creating a lot of problem. Okay, because what is the significance of this thing, that even if we want to plan about central neuraxial block, the problem will be the patient positioning. Okay, so this may be, because whenever there will be pain, there will be stress, and all the problems related to stress in an old man who already may have some baseline cardiac problems. Okay, more chances of, not every patient, but there will be chances of diabetes mellitus, hypertension. So you have to consider all things in your mind, that management of pain will be one of the most important thing. And in addition to that, if there is any CNS or CVS or endocrine metabolic cause, electrolyte imbalance, so you have to consider that thing in mind. So whenever you will be planning this patient, you have to keep in consideration all these things. So discussion with the surgeon will be of utmost importance, because you have to fix the fracture at the earliest possible time. You cannot delay it for unwanted investigations. Yes, you can have some optimization of any correction of any electrolyte imbalance and controlling of the pain and like things like that. If the patient is already been started with anticoagulants, so you have to optimize before having any regional anesthesia plan. Okay, so these are the things which you should be considering whenever you have a, because this scenario they can actually check your knowledge of all of the anesthesia, because related to hip fracture everything is related to. So because our focus at the moment is related to regional anesthesia choices. So first of all, if I ask any one of you, what level, usually what level of anesthesia will be required for pain related to hip fracture? Anyone wants to speak on? Tayyab?
T10 to L4.
Your answer is wrong. Anyone else, please?
T12
Yes, T12.
to L4, 5.
You don't need to tell, because aren't this, just tell me one thing. What is the nerve supply of hip joint? Yes, please. What will be the nerve supply of hip joint?
So para,
Your voice is distorted.
sympathetic and sympathetic both are.
Unfortunately, your voice is not clear.
Sir, it's clear now.
Yes, it's better.
So the sympathetic and parasympathetic have the same ganglion nerve supply for the hip.
Okay.
I remember the ganglions are the same.
What ganglion it will be?
I don't.
No, actually, we are talking about the nerves. So hip joint is getting the supply for all three nerves, all three major nerves like sciatic, obturator, femoral.
Femoral.
Okay, so if the joint is involved, actually you have to uh, block all the nerves. So that's why this concept of this new block, that is SPANG block. Okay, so yes, please. Okay, so actually, because this is something new, recently, few years ago, this block has been documented. I have never done this block, but theoretically, if you want to have understand the chunk, what is the consideration is that actually you are blocking almost at the same place where you are doing the femoral nerve block, but you are going a little lateral and a little proximal. Okay, so you should be thinking that because when you are going a little proximal, there will be chances of entering into the no-go area, haram area, dangerous area, that is the pelvis, by through peritoneal, by that piercing the peritoneum. So you should be, this is one important thing you should be knowing. And what is the rationale that you are blocking the joint nerves, branches of the three major nerves which I told you. Okay, that it is not only for hip fractures, for this degenerative hip disease. And actually, one thing I forgot to mention is about osteoarthritis. Okay, because these patients who are having old age, this is one of the most considering thing in these patients, that there are chances of osteoarthritis in almost all other joints as well, especially the knee. So the positioning, the problems will be the with the positioning will be also because of osteoarthritis. And the bones will be weaker because maybe they are taking NSAIDs and they are taking steroids, which is causing osteoporosis, the steroids. So these things which should be knowing. So when we are giving it, actually we are, the name pericapsular nerve group block was started, like described in 2018. And it is, if some, they can ask you this question that even in the emergency, what block you can give to relieve the pain. You can give this block for the positioning of the patient for this one, spinal epidural. So you will be, because traditionally, practically speaking, we are also giving femoral nerve block, which will relieve some of the pain. Okay, if you are giving femoral nerve block with the lidocaine to start with, it will be easier for the patient positioning. Okay, so but this is some like newer concept. And you see, joint capsule itself is a complex arrangement of articular branches receiving contribution from the four mentioned nerves, as I told you, femoral, sciatic, and obturator. So when we are performing this block, the advantage will be that these nerves, the branches, articular branches will be reliably blocked. So that is the concept of it. As like any other, they will maybe there is some picture I will just show you. Proximal articular branches that innervate the joint capsule. This proximal approach by ultrasound can confer severe advantage over a femoral nerve block by providing more complete analgesia to the hip joint. Additionally, the motor function of involved extremity should be spared. The PANG block can be used alone as a primary analgesic or in combination with other forms of anesthesia during surgery or in perioperative period. For lateral surgical incision, a supplemental lateral femoral cutaneous nerve block provide additional coverage. Because if usually they are giving the incision, that's why the discussion with the surgeon is always important, that what is their plan. Okay. Okay, so okay, so related to this thing, and actually this folder I shared in the morning as well. And this is the guidelines for hemiarthroplasty. And if you want to just have a look at the guidelines recommendation, you have to see that it will be a perioperative care, and you have to plan the whole of the course, because you will just also follow the protocols of ERAS. Okay, because you want the patient to be discharged at the earliest possible time. When I just made this list, one thing I missed is related to bone cement, because surgeon maybe according, I will show you the different types of hip fracture, and according to the type of hip fracture and what procedure they are doing, usually they are also using some bone cement when they are doing the repair. If it is neck of femur fracture and they are doing Austin Moore, or they are replacing it whole. Okay, so the factors which will be having more cardiovascular compromise will be increasing age, significant cardiopulmonary disease. Okay, patient taking diuretics. Why? What is the problem related to diuretics? Yes, please. Anyone?
Sodium electrolyte, sodium potassium pump, not work.
Not. It is related to hyponatremia. Okay, because hyponatremia is a cause, one of the factor for postoperative delirium. So diuretics, of course, other electrolytes as well, but in old age, it is hyponatremia is a big problem. Okay, so specific, you see, the roles inform the anesthetist related to surgeon when they are doing it. Thorough washing, dry the femoral canal. They may be used to the retrograde fascia. These are the things to avoid bone cement syndrome. Okay, So because in the bone cement, when they are applying it, there is exothermic reaction and intramedullary pressure increase a lot. So there is a sudden cardiovascular collapse. There is a picture which is mimicking embolic phenomena. Okay, so you have to be ready for it, and you have to cover, like you have to optimize the patient before and they are doing it. Okay. Yes, Sadhya, Dr. Sadhya.
So this bone cement can also have this anaphylactic reaction, can give rise to this anaphylaxis.
Actually, not really an anaphylactic. This is described as bone cement syndrome. I will just show you the some points about it. Just a second. Let me finish this. I will just show you. It is because it is not only the immunological reaction which is occurring. It is actually the intramedullary pressure which is suddenly increasing and resulting in sort of embolic phenomena. Okay, resulting in cardiovascular collapse. So that's why you have to be ready for it, and you may consider this one intraarterial blood pressure monitoring, and you should be ready. And it is better to anticipate and replace the fluid and correct any. You see, this is how they have written here in the guidelines as well. Okay, just a second. There are certain grades for it. Ask the anesthetist to confirm that he has heard your instruction to the theater team that you are about to prepare the femoral canal for cement and prosthesis insertion. Carefully prepare, wash, and dry the femoral canal. Use of a pressurized lavage system is recommended to clean the endosteal bone of fat and marrow contents. Use a distal suction catheter on top of an intramedullary plug. Insert. These are the surgical things. They can ask you that close communication is important, and they can do it retrograde, and they can make a hole which will deflate the pressure. Okay, do not use excessive manual pressurization or pressurization devices in patients at high risk of cardiovascular event. Okay, like the patient who are at risk and age, increasing age, and diuretics and all this. So ensure the patient is adequately hydrated before induction and during anesthesia. Maintain vigilance for possible cardiovascular events. Once the femoral head is removed and the surgeon has verbally indicated to instrument the femoral canal, confirm to the surgeon that you are aware of prepare. They are actually, because they are giving the guidelines. So to take home summary will be from this source will be that you have to communicate it, and you have to optimize the patient before they are doing it, and maybe you can attach some vasopressor. Okay. Multidisciplinary assessment, timely surgery, effective pain control, reduce cognitive complications, early rehabilitation, and mobilization. That's what I was telling you. Okay. Actually, I'm just trying to find out one things for which you, on the basis of which you will be planning. It's not that one. Just a second. Yes, actually, I wanted to show you, I was not getting it, that you will not delay the surgery. Okay, so only, for example, there is significant anemia, there is significant hyponatremia, there is significant hypokalemia or hyperkalemia, uncontrolled diabetes, correctable cardiac arrhythmias, like atrial fibrillation, for example, chest infection with sepsis, reversible coagulopathy. In these conditions, you can take some time to optimize these things, but you will not delay it for, like, because they have made it guidelines according to their system, but you will not delay it. If you don't have the facility to be done there, you have to refer the patient. You will not delay it, because otherwise there will be high mortality morbidity. Okay, so you will not wait for the echo. Okay, and minor electrolyte imbalance, you will not delay it. This is the thing which you should be knowing when you are discussing. They are asking you about, actually you can say these things in a number of other fractures as well. Okay, but they have devised these guidelines with reference to hip fracture. Okay, these are few points about the routine preoperative evaluation. Okay, because if any, for example, the patient is diabetic, patient is hypertensive, so you will be evaluating the end organ damage related to the diabetes mellitus and hypertension, and you will do the evaluation accordingly. Okay, but usually the things which you will be taking care of, I have told you, because this group of patients will be at risk of certain things. So you have to, and one of the problem which you will be facing, as I told you, is one of the problem in, especially in old age, is delirium. So you have to, and one of the factor for that one is hypothermia. Okay, if you are giving general anesthesia, which is one of the factor, if the patient is having electrolyte imbalance, this is a factor for postoperative delirium. If the patient remain hypotensive, hypovolemic, this will be a factor for delirium, because delirium is associated with the ICU, prolonged ICU stay, and morbidity, mortality. So you have to avoid all the factors which can lead to postoperative delirium and postoperative and prolonged hospital stay. So whatever you are planning, it seems very simple things, but you have to anticipate and you have to act accordingly. That's why analgesia is very important. So now if we just have a look on different analgesia options. So if I ask you what will be the different analgesia options, how will you chalk out? How will you make a list? Opioids. Okay. Paracetamol. Okay. What else? Different options. Combination. Of course, we will not give in every patient. Epidural. Spinal. Combined spinal. CSC. Okay. Then this Pank block. Lumbar plexus block. What else? This 3-in-1
Femoral block. Fasciolata.
all the fasciolata block. What else? Lidocaine infusion. Dexmeditomidine. Ketamine infusion. And post-operative plan will be with the epidural. You can have this femoral nerve catheter. You can have PCA of either morphine or fentanyl. What else? Anything else?
PCA, patient controlled analgesia, multimodal.
The thing which I have written, don't no advantage of repeating them again. Okay, I have just written everything. Anything else which I missed? Any other option?
Entonox,
No. Antonox for post-operative analgesia.
No, sir. Per-operative.
No. Okay. So if you have a patient with atrial fibrillation and coming for this hip surgery, how will you optimize it? Anyone, please? Yes. Because you have
Sir,
to
they will optimize the patient and
okay,
go
how
for echocardiogram
to see what?
to see systolic and diastolic
No,
dysfunction,
no, Dr. Humera, please.
ejection.
Your answer should be better. I sent the data in the morning, and I'm expecting you to be a little bit prepared. Yes, anyone, please. What is the focus thing in
So,
echo? What you have to see in patients with atrial fibrillation?
so we need to do the bridging.
No, echo. Now you have to do bridging. But I'm sorry.
Ejection fraction.
No, Dr. Humera, please. Your answer is wrong. Yes,
Right atrial thrombus.
I'm sorry.
Thrombus. Right atrial thrombus.
Yes. Okay. So you have to rule out any atrial clot, because whenever there is atrial fibrillation, there is a stasis and there may be atrial clot. So if you want to do echo, you have to rule out this thing. Rest of the things will be there in echo for any patient. Systolic dysfunction and this and that, the long list. But if with reference to atrial fibrillation, if someone is asking you, it is specifically for atrial clot. Okay, and you, Zunera, you told about bridging therapy. So how will you bridge it? Because usually if these patients are, because there will be different scenario. This patient may be on warfarin. If the patient is on warfarin, you have to bridge it with the low molecular weight and heparin. Okay, you can stop warfarin and you can start low molecular weight heparin, and then or there is an or if the patient is inpatient, you can have this heparin infusion, and you can stop it 4 to 6 hours, and then you can proceed with the surgery. Okay, because with heparin you can monitor the with the how can you monitor heparin? Yes. Yes, Dr. Humera. How will you monitor heparin?
APTT monitoring.
APTT monitoring or
INR.
I wish that I correct your concepts. INR is not for heparin. Dr. Humera, I am very disappointed from your answers. Tayyab, you are also mute today.
Yes, sir.
Why you are not answering?
Sir, I was on duty.
So you cannot speak. How will you,
No, I am.
How will you monitor heparin?
Sir, first of all, we will monitor by using APTT. And secondly, CBC, we also use platelet count.
No. Tayyab, relax. Take a deep breath. You know it. This is not the answer. CBC, what is the relationship CBC with heparin?
Sir, regarding thrombocytopenia caused by heparin.
No. Of course, with heparin, anaphylaxis can also occur. HIT can also occur. But when someone is asking you how to monitor heparin, what you have to answer, even APTT is not giving you, APTT can be done in the OR?
No.
So what is the
ACT? ACT, sir.
So answer is ACT, activated clotting time, which is we can do it immediately. Even when in the cardiac surgery, when we are therapeutically given heparin for the anticoagulation, we can monitor it with ACT. Okay. So this is how we, INR is with reference to warfarin. The formula is VEPT, warfarin extrinsic PT, INR. And for heparin, it is actually factor 8. And it is through either APTT or ACT. Okay. Well, how to monitor Claxane? If you want to check it out, patient is on Claxane and you want to check it out, is there any test for it? Yes,
No,
please.
sir.
Factor 10 levels. Okay, but it is not reliable. This is why this is important that you, when you are doing the pre-operative evaluation, and you will see people saying the coagulation profile is normal. So actually this is not a technical answer from a anesthetist, because Claxane, if you want to actually, you cannot do anything. You don't need to monitor. But if academic answer in the exam, factor 10 levels. Okay. So this is some options. Okay, so you can add some adjuncts. So pre-operatively, I told you that you have to rule out any serious problem like uncontrolled diabetes or sepsis. As I told you, these things should be in your mind. So you will be managing the patient if there are some serious problems. Otherwise, you will not delay it, because as much as you will delay it, there will be more chances of problems. Okay. So, and monitoring, in addition to standard 1, standard 2 monitoring, you will be doing intra-arterial blood pressure monitoring. You may need, if there is some indication, then you can do the cardiac output monitor in case, because this patient is also at risk of fat embolism. The patient is at risk of this bone cement syndrome if they are using the bone cement. So you can monitor the cardiac output monitor. This can help you. Okay. And cerebral oxygen saturation, I don't know, because of neurological involvement if it is there, but if you in the exam, if you want to answer that in addition to anesthetic standard 1 and standard 2 monitoring, there will be invasive blood pressure monitoring and cardiac output monitoring. Okay. So just a second. Okay, so there is a concept of preemptive analgesia. So you can give for preemptive analgesia, you can give paracetamol, NSAIDs, and this one gabapentin. Okay, it is a protocol which is being used for preemptive analgesia. You are blocking the pain sensation before it's starting. Okay, so rest all the common things which we have discussed a number of times before, that you will be maintaining the oxygen level like normoxia, normocarbia, normotension, normovolemia, normothermia. Okay, this one goal directed fluid therapy, because these patients may be at risk of overload, like they can become and because of old age, there may be incidents of hypertension. Not every patient, not every elderly patient will be alike, but you have to give it cautiously. Okay, if there is at what level would you like to give blood? How much hemoglobin would you like to maintain in these patients? If there are chances of any
Sir, it depends.
Okay.
So it depends on if the patient is cardiology, having some cardiac issues or not non-cardiac issues. And there is a trigger for cardiac issues around 10, and for non-cardiac, it's the trigger is around 7, if
Yes.
I'm not wrong.
Yes, you're right. But actually, the thing is that if you have to replace the fluid, how you replace it? If you are not giving blood, How will you replace, for example, if there
So
is
it depends on the fluid will be replaced with the same type of the fluid. Like if it's a blood loss, it will be replaced with the blood. But if there is a
no,
like
no,
we should
no. For example, if
1:1:1.
no, wrong answer. Again, wrong answer, Dr. Homera. If you want to
3
replace,
ml of crystalloid for 1 ml loss of blood.
thank you very much. Like it is 3 to 4 times with crystalloids or equal volume of any colloid. Like you can give albumin, you can give hemaxil or hysteril, equal volume. Okay. Up till the blood level you can allow. After that, you have to replace it with blood anyways. Before that, for example, if allowable, you are allowing blood loss of around 500 ml, for example. So up to 500 ml, you will replace it with 3 times crystalloid or equal volume of colloids. And after that, your allowable blood loss is reached, then you have to replace it with blood. Okay, so that is the concept. The thing which you are saying 1:1:1 is not valid here. Why you want to replace 1:1:1?
Sir, balance salt solutions in equal amount.
No, again you are talking wrong. What do you mean by balanced salt solution?
Sir, crystalloid and colloids.
You are telling 1:1:1. What is the concept of 1:1:1? Ahmad, would you like to say? What is the concept of 1:1:1? Anyone, please. What is the name of this?
Sir, is it the 1:1:1 is pack cells and then the platelets and FFPs? Is it?
Yes, it is called as
And
hemostatic blood transfusion.
and it's given in massive hemorrhage when we have to transfuse massive blood loss.
Yes, if we have isovolemic blood loss, like for example, if the patient suddenly bled, it is you can say that the patient was a normal patient, suddenly bleed, so you have to replace like that. But if the patient is having chronic anemia, the things will be a little different. So you have to, how can you monitor the blood transfusions? By rotom or tag. Okay. Then whatever products you want to give, you will give like that. Okay. So
what is this thing you have written?
Thromboelastography.
Okay.
Thromboelastography. Okay. Or rotom is also rotational elastometry. This is to see the quality of clot formation and breakage. Okay. So by the help of this, you can identify whether you want to give FFPs, whether you want to give fibrinogen like in cryoprecipitate, whether you want to give platelets, and whether you want to give antifibrinolytics. Like, which is the antifibrinolytic we use commonly? Tranexamic acid. Okay. We will discuss at some time with the trauma, we will discuss it. Thromboelastography. Okay. So initially FFPs, the angle, there is an alpha angle. This is cryoprecipitate. If there is maximum amplitude is not achieving, it is platelets. And if the clot is making but breaking quickly, so it means there is accelerated fibrinolysis. So you will be giving antifibrinolytic. Okay. So this is how we will target. Okay. So any questions, please? So like if I just summarize what I have discussed up till now, that we discussed about hip, we are discussing the scenario of hip surgery. What are different analgesia and anesthesia option? Now what may be the possible combinations we will just discuss, but we just try to see that which patient age group is there. Yes, I wanted to show you different types of hip fractures. Just a second. It is because the variety of I forgot the name of, see, that is they have neuromuscular status, cognitive status, fall initiation, fall direction, energy content, fall descent, like how it is occurring, the etiology of this. There is actually I forgot from where I had read it. Different types of femur fractures. Just a second, please. Actually, this is what I am telling you. This is the source is here. Okay, like this guideline. Yeah, this is the same thing is reproduced in the article as well. So this is the AAGBI guidelines for femur fracture. Yes. Okay. These are the different types of fractures which can occur. And if I will see which one of the fracture is, I think it is intracapsular, which is creating more problems. Okay, just a second. These include inter-subchondric fracture and can be further divided into groups related to degree of comminution. Blood loss from cancellous bone is greater, such that the total blood loss from an extracapsular fracture may exceed 1 liter. The greater the degree of comminution, then the larger the bone fragments, the greater the blood loss. Why it is important for you to be knowing that certain fractures will be having more blood loss. Okay. Invariably, extracapsular fractures are fixed surgically using either a sliding hip screw, intertrochanteric fractures, or less commonly a proximal intermedullary nail, which is for subtrochanteric fractures. Okay. So you can just have a look here. Because I don't memorize it. So you can have a look here. It's there in the link which I shared to you. You should be knowing about it. Because practically, when we are in clinical practice, things are a little bit different. But from the exam point of view, this is a source you can follow. This is femur fracture guideline from AAGBI. Okay. So if you want to make a plan, you can have either combined spinal epidural as a sole agent with a little bit of sedation, because what is the problem that usually majority of the fractures, they will be done in the lateral position. Okay, so in lateral position there are certain changes which you are anticipating. So maybe some patient will not be able to be on the side for 3 hours. They will feel uncomfortable. And another thing is that maybe it depends on that's why you will be discussing with the surgeon that what they are expecting. It can be done purely in spinal. Like one of the combination will be that you are giving spinal, and for post-operative pain you are giving nerve block, or you are giving PCA. So this is one of the plan. You are giving post-operatively, you are giving the wound infiltration, and then you are giving PCA. So this is one of the option. One of the option, as I told you, that you can have a combined spinal epidural. You can separately, you can do it with epidural as well. So there are so many options. In the exam, you will say that these are the different options. And for individually, you can have a plan. If you are giving GA, you can still give an epidural for post-operative pain relief. This is another option. Then intraoperatively, as I told you, that there is a concept of giving lidocaine IV. There is a concept of lidocaine IV. I have discussed this thing number of times. If it's new to you, actually it is blunting the stress response. It is doing a membrane stabilization effect because of sodium channel blockade. Okay, so the stress response is blunted and there is a very good response. Then there is another option is dexmeditomidine, which is also a sympatholytic, and you can give you can have a infusion throughout the procedure. You can give it. Okay. Similarly, people are also using very low dose of ketamine infusion. It is also very good for pain relief. So you are making a combination according to the scenario. If you are suspecting there is some baseline because of osteoarthritis or hypertension or diabetes, there is some renal risk, so you will not give NSAIDs. You will be trying to avoid NSAIDs. So this is how you actually anticipate. As and the other block which we discussed was spank block. So this is a whole concept. You see, if you now think you are expecting bone cement syndrome, you are expecting fat embolism. Fat embolism occur, what will you do? Who will answer? What will you do if there is fat embolism? Tayyab? Yes, please.
So we will keep the transesophageal echocardiography.
Dr. Humaira, please. You are coming with a very terrible answer. Very, very terrible answer. Why you are doing echocardiography, a transesophageal echocardiography for fat embolism? This is for air embolism. Only for detection. In emergency, if they are asking you scenario, your answer will be, my approach will be airway breathing circulation. I will make sure patient's airway is patent. I will be giving 100% oxygen. I will try to secure the IV lines if it's not there. If it's there, you will start the fluid therapy. And if the patient has cardiac arrest, you will follow the ACLS protocol for the cardiac arrest. If the patient is hemodynamically unstable, you will be starting the inotropic or vasopressor support. The transesophageal echo will be helping you in recognition if the heart is failing. But you will not, if the patient is collapsing, would you like to start echo before giving oxygen? Not at all. Okay, so just try to think before you are answering. Why I'm squeezing you more? Because you are in touch with me. These majority people are new, but you are listening to me. Even this topic, I think you have listened to me multiple times. So I am expecting a better answer from you. I have discussed this topic a number of times before. So airway breathing circulation. Same is answer for bone cement syndrome. Same is answer from venous thromboembolism, because there will be chances. So one, if for example, venous thromboembolism occurred, what happens? You know, if I will ask this question to a junior, Zunaira, please, can you explain what happens in embolism?
So, I am not sure if I will be able to explain.
No problem. Try. This is a common pathway for any embolism. Actually, what happens? Whether we have fat, or whether we have a thrombus, okay, or whether we have amniotic.
It comes in the emergency protocols. Of course, we will go with the ABC.
No.
And what I know,
this is not my question. What happens?
Okay.
Why there is hemodynamic collapse in embolism? Ultimately, they are entering the great vessels and they are blocking the pulmonary artery. Okay. So when pulmonary artery is blocked, the back pressure, what is this? This is right ventricle. So right ventricle is a miskin. It's a simple one. It is not tuned for high pressures. So it will fail. Okay. So when it will fail and there is nothing going to lungs, there will be no cardiac output. So that there is hemodynamic collapse. This is the common pathway for any embolism, whether it is air, whether it is thrombus, whether it is fat, and whether it is amniotic fluid. This air and thrombus, if it is big, this is more acute than fat and amniotic fluid. Okay. Understand? So this is the concept of embolism. Whenever there is any embolism occur, this happens actually. Understand?
Yes, sir. Thank you so much.
Okay. So just have a look at it. And you, if any question or anything which I have missed, you can come back and we can discuss later on. BIS is because I saw this BIS monitoring. BIS monitoring is if you are giving GA. Yes, Dr. Kamal?
Yes, sir, what about tachypnea and decreased CO2 in embolism, PCO2 on monitoring?
Just a second. What did you say?
Okay. Tachypnic, the patient become tachypnic and decrease end-tidal carbon dioxide level in any embolism.
Or how this end-tidal CO2 is coming? From where it is coming?
So from the lungs?
Yes, from lungs. From the lungs. How our body is making this CO2 factory? It is through the circulation, cardiac output.
Yes.
So when there is no cardiac output, there is no oxygen, there is no CO2 production. So this will go.
Okay, sir.
Okay.
Okay.
And tachypnea? Why
Thank you.
tachypnea? Why tachypnea? Why tachycardia? Tachypnea. Why? This is all because of hypoxia. Low cardiac output, there is sympathetic response. As okay. As a last
Okay.
ditch effort from the body. So tachypnea, tachycardia, these are all signs of impending failure. Okay. So CO2 goes because why in air embolism suddenly there is loss of end-tidal CO2? Because suddenly air has blocked the pulmonary vessel. There is nothing going to the lungs. So from where CO2 will come? Because whatever end-tidal CO2 is coming to, if you see that's correlated. If you have severe hypotension, the end-tidal value will go down. Okay. So this is actually everything. Just have a look on this guideline. Okay. And if any question, you all are welcome. I have I wanted to discuss knee as well, but I think knee we will do it separately. Okay. So thank you very much. Any questions before we finish? You understand? Because actually I just try to, I'm not focusing on the landmark or for regarding the blocks. I will just tell you one thing before we finish. And just a second, please. For any
Sir,
block.
how
Sorry?
will we treat this embolism?
Who asked the question?
Sir, I asked, how will we treat this patient?
Hemodynamic support. That's it. If it is thromboembolism, then you will consider this one, thrombolytics. Okay, but initially you have to go with the hemodynamic support. Okay, regarding the blocks, I just want to tell you that landmark you should be knowing. And usually there is always, if you are doing it under ultrasound or under nerve stimulator, neuromuscular stimulator, remember one thing, under ultrasound, usually in every block there is a vessel. You will be looking at some artery. Whenever in majority of the blocks, nerve blocks, there is always an artery, either lateral or medial or superior or inferior, or there will be nerve usually. Okay, so this is usually under ultrasound, you are visualizing or locating the nerve with some vessel. Traditional landmark will be according to anything, like for example, if you are talking about femoral nerve block, you will be looking at the femoral crease. Okay, and there you are measuring the distance from the anterior superior iliac spine to the pubic symphysis, and I forgot because we are never using it now, but for exam point of view you should be knowing it. And the nerve stimulation corresponding muscle group, like if you are considering about femoral nerve block, the movement will be at the quadricep it will be the knee jerk response, okay, with the quadricep movement. So this is actually true for any block. You endpoints are this like this, and in endpoints maybe you are hitting a bone or you are entering in a vessel. This is also common for any nerve block. If you are entering any bone or vessel, you will withdraw and redirect. Okay, so this remember one thing. And for any nerve block, if they ask what are the complications, failure is a complication, incomplete is a complication, okay, hematoma is a complication, visceral injury, maybe in some blocks you are able to doing some visceral injury also in the upper limb, the blocks, the visceral injury is pneumothorax, it's a visceral injury. Then there are unwanted nerves which are being blocked. The example will be here that, for example, you are giving upper limb block and you are blocking phrenic nerve. You don't want to block phrenic nerve, but it is blocked. So this is another thing. And then there will be some, like if you are managed to doing any nerve injury, so this will be a little delayed. Okay. So another complication is delayed effect. You are unable to get the response out of the, so if you are adding dexamethasone, this is one of the factor, or there may be in different patients response may be different. So these are common things about any nerve block. And last but not the least, you should be before that you have to say about consent. You have to tell about the safety, not only the medication and necessitated equipment, you have to calculate the dose. Okay, you have to calculate the percent concentration which you want to give. So these are the things which you should be knowing whenever you are dealing with any nerve block. Okay, so thank you very much. So in next setting we will just try to discuss knee surgery. Okay, so just you should be knowing the NCN where they are giving, what type of fracture is it, bleeding, pain, thromboembolism, age group, a bedridden patient. Related to that, there will be UTI, there will be need for antibiotics, there will be need of thromboprophylaxis, adequate pain relief will be there, and you have to correct possible things which you can, any electrolyte imbalance you can correct, and any fluid loss you can optimize before you proceed. And then you make a plan according to the multidisciplinary team. If you should try to reduce the hospital stay so that you are able to ambulate the patient at the earliest possible time. Okay, so any questions? Okay, thanks for your presence.
Thank you, sir.